program. So hemodynamics, there is epic hemodynamics, there is epic infections, epic on respiratory care, brain health. So we have different teams in different centers, and we have the national centers in entire Canada, and each center we have a group, and the group including physicians and nurses, the clinical resources nurses, like the CRNs, and even the inside nurses.
لسه بعتلي النهارده الصبح جوهير ورك شوب عندهم في واحد في الدرجه لسه بقى سيرة على السيرة
صحيح.
والله بعتلي اهو.
Okay, so we'll start first case scenario. Any question in your mind you can ask. Now we are this friendly discussion. So there is no good or bad question. Every question is respected. So golden hour for support and anything is not clear during the discussion, just let us know. So, like, probably they speak maybe it's a Canadian English, so when we have some abbreviations, so let us know if you have any question.
الحاجات اللي احنا عايزين نقطعها على اللابتوب هنعرف نجيبها ولا لا؟
الباوربوينت نفسه؟ لا
اه
هما فيديو ما ماتش الباوربوينت.
مش على اللابتوب؟
على الفلاشه.
ناخدش نسرق الفلوس.
Okay, so we have the first station, first case scenario. Our golden hour support congenital diaphragmatic hernia. So at the end of this scenario, like we are going to demonstrate the preparation and the checklist for congenital diaphragmatic hernia in the delivery room. What we need to prepare if we are anticipating a case of congenital diaphragmatic hernia. I know that might not be applicable for all the cases because more than 90% of the cases they are already known antenatally, and we already contacted the family and we have everything ready in the delivery room. So it's anticipated delivery. Our support.
ممكن بس المايك
Can you hear me now?
No.
Okay. So the first case scenario of congenital diaphragmatic hernia during the first hour after birth. That will include the preparation checklist and also the initial golden hour support. The initial just a few minutes after birth, which is really very important. And during the golden hour support, it means that we are anticipating. So more than 90% of the cases, more than 90%, right? It's already known, and we are anticipating. We have the most senior person, the neonatologist, should come and attend. So overnight, if I'm at home and the neonatologist covering, I should come enough time before delivery with the other team. And we have the most senior fellow in the neonatology program, and maybe a pediatric resident, 2 or 3 nurses, and 2 respiratory therapists, and a pharmacist. So that's the team that should attend and really, as you can see here. So let us start the first part. So Robert, yeah, he's asking about the appropriate gestational age for delivery. So usually we prefer to wait. I will answer and I will let you also comment here. Prefer to wait until 37 weeks. So try to avoid premature delivery because that will add more risk to the delivery. Unless there is any kind of maternal risk, like maternal preeclampsia or anything, but you cannot wait. So you have to justify if the obstetrician asking if like the communication for any delivery before 37 weeks, we should be notified and we should agree with the obstetrician. The obstetrician cannot go for any delivery less than 37 weeks without asking our input. And we have to justify why you would like to deliver a baby for 37 weeks. And we have to be sure that there is a secured bed in the NICU for the same case, either the case in our center or the referring center. We don't have level 3 NICU. So before 36 weeks, unless there is any clear maternal or fetal indication, there is risk for the fetal on the fetus as well.
Yeah, I don't think there's any reason to induce a mom with diaphragmatic hernia. The only reason it could be that you want to time the delivery so it doesn't occur at 3 o'clock in the morning. That would be the only reason.
Yeah.
But ideally, you want to wait at least until 39, 40 weeks, like a normal delivery, for mom to go into labor. But again, sometimes we discuss with the nutrition that we want the whole team to be there, ideally in the daytime, but you don't want the delivery to happen at 3 o'clock in the morning. That's the only, but there is no reason to induce otherwise.
Yeah. So they have like a communication, any issues, quality-related issue, communication with the obstetrician, sometimes making decision by themselves without communicating with the neonatologist.
Very frequent.
So that's a quality issue. Yeah, you need to make a maybe quality improvement to sort it out how to solve this problem, because that's really very significant, will have very significant impact on your outcome.
Yeah, it should be working as a team.
Yeah. So let us listen to the first part of the team.
Okay, so I have our congenital diaphragmatic hernia pre-delivery checklist. Let's just go over it quickly. So I've obtained the history, and then I'll continue to do documentation.
Okay, looks like I said it most forward.
And I've got the solutions ready to go. And contact pharmacists and medications.
Okay, sounds good.
Okay, Ron, so I have our congenital diaphragmatic hernia respiratory checklist. So I can just go through it. I'll assist with the intubation, so I'll be part of the airway management.
And I'll take care of setting up the conventional ventilator, turning on the graphics, getting the jet ready, and the nitric is here and I'll key that in.
Okay, and I'm just going to double check the massimoles are on and disconnected with 2 probes available. And I'll also get the inline section available and just go through and check the equipment.
Great, very well.
All right, perfect.
So everybody has their individual checklist completed?
Yes.
Okay. We can review the history when the PEDS gets here.
Yeah, so there is a lag between the sound and so we'll have to use the sound for
Okay, so I have our congenital diaphragmatic hernia pre-delivery checklist.
think the system does not like the video embedded in the PowerPoint. So I have a golden hour for a different case scenario until we get this case scenario for me. I can use a video for other things. Just go back to the slide. So I'll just go through a simpler case scenario for a preterm infant and how we set up the CPAP in the during the hour. So we'll watch that first, and then I will until I get the video for the congenital diaphragmatic case. So we'll start with this single video.
Okay, so you have a 26-weeker that's getting set up in the case room. As we have the transition checklist for infants born less than 33 weeks ready?
Yeah, right here.
Okay, perfect. Okay, so I have the history here.
Okay. I can go call NICU and IMCM to let them know about the 26-weeker.
Okay, and I'm going to check the airway and CPAP supply. Okay. So I just got page. So this is a 26-weeker? Yeah, we're just getting set up here. Yeah? You guys are going through the checklist?
Yes. I will still assemble the peripheral IV supplies.
I'm just getting the bed set up with the warmer. So I notified the neonatologist. He should be here right away. Was there an antenatal consult? I think there was on this one, right?
There is, yeah.
Okay.
I'm just starting CPAP. Do you want me to start at +6 or +7?
I think we'll start at +7. So why don't we go around and kind of identify everyone, and then we'll just talk about the plan. So I'm Nicole, I'm the nurse practitioner today.
I'm Monica, resus nurse 2.
I'm Lindsay, I'm resus nurse 1 today.
I'm Alita, sergeant there.
And Dr. Alvero, neonatologist.
Okay, and so you have the history?
I do, yes.
Okay, so we have mom is 32-year-old, G2P1, 26 weeks today. All the serology is negative. We're doing an elective section for maternal PIH that has been uncontrolled. Steroids have been given 2 doses 2 days ago. Meg sulfate was given yesterday. Babe has no fetal distress.
I already talked to the pediatrician and he's going to do a neonatal plan.
Oh, okay. Sounds good. So you're going to go get the baby then?
Yes.
Okay. Okay. So we'll put her, right? It was a female. We'll put her on the bed in the wrap, CPAP 7, and you have it at 30%? Okay. And then we have airway supplies set up in case the baby's apneic.
Yes, I have a 2.5 in the 3.0 and a 00 and a 0.
And do we have a surfactant?
Surfactant is available.
Okay.
Drawn at packing.
Okay, perfect. So you got your leads here, and Massimo's ready to go. Babe was vigorous. How do we cry?
Timer started.
I'll lift him up. I'll pull the blanket out.
So it is a minute of delay for mapping.
Okay. I'm going to put the nasal CPAP on. It's +7. He's good. Okay, I'll hold that for you. We're on 30%. And I'm going to put the hat on. Okay, so after our timer's on, Lindsay's got the ECG leads on, and let's just get a preductal stat monitor on. So the stat monitor's going on. We got a heart rate already. 108?
Yeah. 30%. And we're how many minutes old?
Sorry, he's just not tucked in here yet.
Oh, sorry. 1 minute.
Okay.
Do this other side.
So I have the peep still. You know what I see? He's got some secretions in his mouth. Lindsay, do you mind suctioning his mouth, please?
That's a good.
Okay. Okay, do you want to do weight?
7 and 31%.
Sure. Okay, so we're at 1.5 minutes. Heart rate's 130, stats of 78.
We didn't go around the call, so I think we're gonna wait for the lines to make ID now.
Okay, just a peripheral IV then? Okay. Okay, weight 780.
Receptor 86.
Heart rate good.
26%.
Breathing shallow.
Here are your OG supplies, one please.
So as far as surfactant, we'll wait and see in a little bit, see how she's doing, how much O2 she's on.
So that is eager to come in, so let me know whenever you're ready.
Okay, so peripheral IV, D10W, K580, okay with that? Okay, I'll go start. Okay. Okay. Okay, so just neonatal protocol then and CBC. Okay, I'll start the order.
Okay, so in this case scenario is that when you say a 6-week aborted see that was going down without being surfactant. Now we can recognize with the 2 nurses and 1 nurse practitioner. In North America, the nurse practitioner, she has the same rule of the in-house staff. The same rule of the in-house staff. So she can do anything that the physician, in-house physician can do, but she cannot make a decision by herself. So that's the rule of the nurse practitioner. And I think there's only in North America. There's no nurse practitioner education elsewhere outside North America. So I think you recognize in the last 2 minutes at the end, after the baby is born, in 2 minutes, CPAP was on, connected to the monitor, and there were 6 hands inside, and each hand knows exactly its own rule, and everything was done in 2 minutes. That's a good, you can, not good out, that's a good minute. And CPAP was on without any kind of bagging or any intervention that can impact the lung expansion. So, like now we can have your interaction or question before we apply the first scenario.
في اكشن كده عملته ناس كتير
Yes.
انا مش عارفه هي عملت ايه.
So there is electronic the way the baby in the mouth. So we get the weight because we need to adjust the caffeine dose. The caffeine should be given as soon as possible. As soon as the IV inserted will be 5 minutes.
ده كويس. بص لما بسأله حد كان فاهم ولا تعمل مش فاهم.
Yeah, that's like the electronic scale.
I have a question. When we are expecting a baby with 26 weeks, don't you see them in a plastic bag from the start? I see that they found him at
No, the plastic bag is usually on the station, like a set.
So you see that in Iraq?
Iraq, yes, yeah. Yeah, Roman, if you'd like to interact, you can.
Yeah, unless it's a C-section. What we do sometimes with the C-section, we put instead of a bag, we do a perfusion that's going to do the C-section. So when the baby is delivered, they put the baby inside the plastic far away, and they do the delay cord clamping while the baby is inside the bag on top of the mouth. And then after a minute and a half, we cut the cord, and we take the baby on the plastic bag to the recess. But if not, the baby is kept on top of the mom, the normal delivery, and then we scoop the baby, and we bring it to recess, and we put it inside the plastic bag.
So you don't practice delay cord clamping and some central practice delay cord clamping and see that in the delivery room for mothers.
Yeah, we don't do that.
Yeah, no,
not for a 26 week. We do that sometimes for an older baby, late return, but not for a 26 week.
The 26 week we just apply 30 to 6 minutes for the planning, and like we start the baby might do it by himself, and then we take the baby after that. But we are not really applying yet. The station one is about step to next. But it is now then I already published articles about the history of daily cosmic clamping, and we recommend based on some guidelines And in some situation, you may apply relaxation and move bag and mask while the whole structure is still connected. So the problem is we need in this specific case scenario to start CPAP, and let the baby breathe. So that's why we did not apply bagging. And to apply CPAP while the cord is still connected is very, very challenging.
Some ventilator companies have a long tubing for CPAP to assure that CPAP applied on mothers.
Yeah, but I'm not sure if the long tubing will be really physiological in that applicable. But to deliver very high pressure, so very long tube. And that's
But you do apply delayed cord clamping in 26 weeks before starting any respiratory assist.
Yeah.
This is ideal because in some centers they say the very premature babies they should be receive the respiratory assistance as a priority and not the delayed cord clamping. And I think this is not physiological.
No, delayed cord clamping, but it's the best to apply to let the baby breathe.
Yeah.
For the two or three reasons, ideas, like just explain the physiology behind this.
Now, what you're asking is very important.
Yeah.
So the question is whether if you start implementing the CPAP while the baby is still attached to the cord, you will make a better outcome. That's a question that it's a good question to ask. But we don't know the answer to that. But you may have a point there.
But
maybe it's
at
more
least
physiologic to.
But at least if you are going to prioritize the delayed cord clamping rather than the resuscitation.
There's no reason to cut the cord too soon in any preterm baby unless there is a significant asphyxia or placental abruption or something like that. Yeah. Otherwise, just 1 minute at least.
Yes. Less intraventricular hemorrhage, less neck.
Less problem with blood pressure, more stability. The advantage is already cool.
So this baby, we are running the usual NRP. There is nothing specific for CPH.
The only thing specific is this applying the CPAP. So you don't wait for the baby to grant or to. That's prophylactic. As soon as the baby is put on the bed, you apply the CPAP.
But I guess also in the NRP, it's a 26-weeker CPAP is recommended.
But what I think is, we need to be sure that we call early CPAP, prophylactic CPAP. There are two different things. This is prophylactic CPAP. Okay? That's one of the first things you do is you apply the pressure. And somebody should be ready right away as their team to have everything ready. As soon as the baby put on the bed, that's the first thing you do.
Okay, so any other question about this?
معلش يا دكتور هو ده كان سي دي اتش with
No, we won't
26 بس 26
Yeah, so we confused
ما اصلا انا 26 بس مش
26 week without CPAP.
سؤال تاني معلش يا دكتور بالنسبه السباب this سباب the same it will be on the baby in the NICU or you will make reconnect again to another machine?
Yeah, that's a very good question. So Ruben, that's what I'm asking. Are we using the same CPAP set and keep the baby connected to CPAP while transferring to NICU in the same machine?
Yes.
It's very important.
And actually, we feed the baby in the same incubator. We transfer the baby on the incubator.
Yeah, so the entire unit
we
will
don't
be
move
the
the baby
same.
around. The less you move the baby, the better. So the incubator that you saw there is the one that's going to be moved with the baby to an ICU and will leave the baby there for at least another 3 days. Yeah.
Yes.
But here, we are applicable to our.
Yes.
We use
Nuva.
Well, I don't think that it is actually available in the different units outside unit. With maybe less expert team, like the pediatrician, not the neonatologist.
We are showing you the ideal situation. That doesn't mean that that's what we do all the time in the whole province.
Yeah.
So there are babies that are born up north in the middle of nowhere, and then you have to sit with them. This is the ideal situation. Babies born in a level 3 unit in our hospital.
Okay, do you have any other question before we move the same scenario but the infant did not tolerate CPAP and require intubation? Yeah, go ahead.
So that's the very nature of have to consent to refer to the intervention. Right? في administrative
Very important question. Yes. Yeah. So yeah, he's asking the communications clearance before delivery, and what kind of consent we get from them before we refer our delivery.
So we ask first. Well, usually we do a consult to all expected preterm deliveries, and we discuss with the parents the management of the baby, what's going to happen. The first question they ask is, "I'm going to be able to see the baby or not?" So we said, "For sure." The baby is very small. We let the baby be with mom for the time of the labor or clamping, but then we take the baby away, and then before we move the baby to an ICU, we bring the incubator to on the mom's side, and then she sees the baby, she touches the baby, and we move the baby to an ICU. We take consent for blood products, and we take consent for donor breast milk. Okay? And it's a regular consent form for admissions. That's routine. But for donor breast milk, we try to get the consent as soon as possible, and blood products.
Yeah. Donor breast milk is provided for any infant with birth weight less than 2 kilograms until the first 2 to 4 weeks after birth, according to the case, and then we produce. If we don't have enough breast milk,
we make a lot of emphasis on the benefits of express breast milk.
Yeah.
We do that at neonatal. And I usually tell the mom that the colostrum is gold for the baby. To really emphasize the importance of providing that colostrum to the baby as soon as possible. Okay? And our aim is to try to expose the baby to mom's milk before 6 hours of age. And ideally less than 2 hours. So the sooner you expose the baby to a mom's milk, the better. Okay? Even if it's a few drops. And if you don't have enough volume, usually we take a cotton ball and we put the milk in the mouth.
Usually the mother can get it before 6 hours?
Yeah, it's just colostrum.
just a few drops.
You won't get the volume for MEF, but you will get a drop or two, and then we use that to paint inside the mouth. And expose the baby to mom's.
This goes for every baby, not sick.
No, every premature baby.
We're talking about premature care.
We're talking about premature babies.
Yeah. And probably it's very important to we need to maybe emphasize the importance of antenatal consult. So if we are anticipating antenatal premature delivery, so this 26 or any kind of higher risk delivery, less than 35 weeks, the obstetrician will let us know there is anticipated premature delivery, and for sure they know that they have to start steroids, and if high risk of infection, start antibiotics. Also, and we need to go and speak with parents, and we let them know the plan. That might take maybe half an hour to 1 hour counseling about what we do in NICU from the time of delivery to the time of discharge, and we let them know about all of the short-term and long-term risk or outcomes, and including also the initial investigations, what we do initially, the lab work, the initial lab work, follow-up, head ultrasound, ROP exam, and everything we do, we need to anticipate that and ask us about questions about the outcomes. And for very extreme premature, like 20, the borderline viability of 20 to 23 weeks, we ask them if they would like to consider everything for support, considering the high risk of developing poor outcome in the future. So that should be detailed and discussed with the family, not at the time or not after delivery. It should be discussed before delivery, once we know there's anticipated premature delivery.
Including the ventilation and safety.
Everything. That might take maybe 1 hour discussion. And they might actually go to internet and search, and they may have more questions and come ask, like the arrange another meeting again with us.
Have you heard about the FICARE concept? Family integrated care. But that's what we try to implement in our units in Canada and Winnipeg. So we try to involve the parents as much as we can. Okay? We want the parents to be part of the team, not just an outsider. Okay? So we try to bring the parents to the bedside, unit rounds. Sometimes we ask them to present the baby, give them the name, the date of birth, the bed number, and some parents will actually get so involved that they will be able to present what happened in the last 24 hours with their baby in terms of weight and fluids and events and whatever happened.
Yeah, you'll be surprised that maybe some of them almost ready to be a nurse at the end, close to the end of this hour.
And that starts
from the
prenatally.
involvement.
So you start involving the parents prenatally, and you tell them the importance of them to be present during rounds and in the during 24 hours a day.
Yes. Yeah, so we encourage them to present during round. They ask questions during round. We have to summarize because we speak maybe medical terminology or maybe complicated discussion with the team during round, and then either the pediatric resident for training or the fellow or the neonatologist at the end should speak and summarize everything in the plan. They may have some questions. They may say they may not accept the plan, and we need to listen to them. They may have some concern about our plan, and they may ask to change our plan when we do that sometimes. Yeah, go ahead.
Whenever the parents are integrated in the plan and in the management, sometimes in any issue there are incident events, there are malpractice.
That's what I think.
Sometimes whenever the parents are involved in every single detail,
yes,
and in any NICU you may have an incident event, any form of malpractice. How you do they accept and how you will explain this?
So like there's two situations: either they attended around and they know it happened in front of them,
yes,
or they are absent.
Yeah.
So in both situations, we have to sit with them and explain to them everything happened. So, for example, infant was given extra dose or wrong dose of, for example, any medication, antibiotics, which might lead to the toxic level or not. And like that happens maybe every year, maybe 1 or 2 times or so. We try to minimize. So there's an action plan on that. First, we have to investigate as a team. We'll not punish who did that. Because that's human error. Might happen to anyone. So we have to investigate why that happened. And we may change our guidelines and the management based on that as a quality improvement. We need to improve that. So we need to have a plan for why this happened. That's from our team. For the parents, we have to sit with them and admit to them that already happened and that considered as medical error.
And they accept.
Like it's up to them. They may do anything.
Our hospitals have a policy that we have the obligation to disclose any errors 100% of the time. You can't hide anything from the parents. Then it will be up to the parents to decide what they want to do. As a hospital policy, you cannot hide things from them.
Even if
we disclose everything. And most of the time, when you do that, the parents will be okay with it.
Yeah.
Because you explain what happened, and some of them will get upset at the beginning, but they will be okay, most of them. So they won't have any relationship with that.
Yeah, I remember just one of the most significant incidents happened during my experience with the old hospital. One of the nurses, she's actually trying to cut a dressing around IV insertion. And the extension of the coverage was extended to the finger. So accidentally she cut it part of the finger or skin, like incident. So this incident was disclosed with family, and they were really upset. But like immediately we asked the plastic surgeon came and repaired everything. Everything was okay. So they were okay with that, but this incident was actually in the media. So it was like every year there's the TV or radio, they come and ask the hospital to explain to the media some of the incidents happened. And it was actually it was in the IPTV of the radio.
Actually, sometimes it's even not an SO report. For example, the baby born with herbs.
Yeah.
This might occur. It's something that's written in the literature and everything, but the parents are not, for example, accepting, and they will sue the hospital in spite of this.
It's their own rights. You can do that.
Yeah, of course.
Yeah.
They have the right to do that.
Do you practice antenatal expression of maternal milk for the expected preterm baby? Do you collect it and because it sounds very promising?
Yeah, the problem with that is that it's studies showing that if you start doing that, you may actually induce preterm labor. So
it wasn't confirmed. The induction of uterine
that's the only
contraction.
controversial issue. But and some parents will ask you about that. So so it depends. Yeah, if I know that, let's say you have a mom with preeclampsia, that she's going to have to be induced or delivered at 27, 28 weeks, and she's not at risk for preterm labor, then I would say, yeah, you can try that if she's willing to do that. But if she can't already on preterm labor or threatened preterm labor, I'm not going to ask her, well, why did you start pumping? And say, no, that's fine.
In the delivery room, attended the delivery in the delivery room, attended the delivery of a 26-weeker, and as Dr. Yasser said, everyone knows his job. So there was a group, a team managing the unit, and a nurse collected 26 people, and I found I was preoccupied with the second insertion and management, but I found the nurse came with a 3 syringe, 5 ml syringe, 3 of them, full of colostrum, and I asked her, what are you going to tell him now? She said, no, we are going to start with all
Yeah, we actually have a kit that we give to every single mom delivery of preterm labor. They have a Q-tip, a syringe, some information, and we give that to the nurse that is looking after the mom, and then hopefully we can collect whatever. Sometimes it's just a few drops, sometimes it's a few ml.
It's oral immune therapy.
Yeah, it's called oral immune
Even
therapy.
infants not on feeding, they will stop feeding from the beginning for any premature infant.
We don't delay introduction.
As soon as possible.
We use MEF, minimal therapy, for at least 3 days. And the sooner we start that, the better.
That's for weight less than 1,250 grams. But any infant more than 1,250, we start the protocol from the first hour for feeding. The protocol is related feeding, but minimal enteral feeding for severe IUDR, less than 10 centile IUDR, or less than 1,250 grams.
There are very few contraindications to start MEF right away.
Yeah. Even HID and cooling, we start feeding.
Because there are reports starting doing total enteral nutrition for the extremely low birth weight neonate with prenatal collected breast milk, and they have got excellent results.
So for the family integrated care, where most of the units now in Canada reside as single rooms. So any new unit or the renovation they design, as maybe showed you the picture yesterday, is a big room which can allow the parents to stay overnight in the room. And they have the facility, they have the lodge access, they can stay overnight. The social worker can provide them support if they need support transportation. If they need to stay close to the unit, there is a donated house.
McDonald's and so on.
Yeah, Ronald McDonald's house, yeah. It's donated from McDonald's. So in each unit closely, they can stay for whatever time. So like, kind of we do as much as we can to keep the parents close to the baby, even if they are from outside the city. But not all of them, because we are level 3 covering the entire entire province. So they might be 2 hours, 3 hours, or maybe flight distance away from the city. So if they need to stay long time, the system can provide support to them to stay longer time with their baby and provide support, kangaroo care, on daily basis. And it's open, they can stay even 24 hours.
Yeah, the fight care involves first educating the nurses, so the nurses can educate the parents at the bedside. We educate the parents. Sometimes we have sessions once a week or every 2 weeks that one of the neonatologists will invite all the parents to come in, and we can talk about problems related to prematurity, feeding, PDA, ventilation, and then we wait for them to ask questions. Sometimes we provide some food or to give some incentive for the parents to come in. And then we have also a group of parents that have ex-preemie babies in the unit that will come in and will interact with the parents. So, yeah, parent support groups. That's part of the fight care program.
Okay, so now let us move to the next.
How many babies for the consultant to be seen in your unit here? How many babies you are seeing per day? During the round, for the consultant, for the...
You mean the admissions? Okay. So in NICU, we have 2 hospitals in Winnie. So in NICU, there is actually an acceptable ratio, like how many beds for each consultant, and the same like nurses. This is like ratio for to get the best care. So for level 3 in ICU, it's around. We have most of our units mixed level 2 and level 3. So we have the Women's Hospital up to 60 beds. So we have 3 teams running for the 60 beds. And there is 2 level 3 teams, each one about maybe 20 cases. And there is 12 beds for level 2 for a different team. So each team with a neonatologist for the level 3, 2 fellows or 2 in-house staff, plus 1 or 2 respiratory therapists, plus a charge nurse, and a pharmacist, dietitian, sometimes a social worker, and some occupational therapist. So that's a team. The team running around in the world, moving all together at the same time.
They will see 20.
Yes. And we finish usually, we start around 9 o'clock, exactly sharp 9 o'clock, start round. And then we finish usually according to the acuity. Sometimes we finish 11:30, 12. We try to finish as much as we can before.
According to the acuity and according to the neonatology.
Yes, exactly. Because sometimes there's some neonatologists who like teaching more, and if we have to get a prisoner, we have to include also some teaching during round questions. And some of them they ask a lot of questions, so that might actually affect the time. But we try to finish before noon, because the pharmacist we need to get all of the orders for the TBM to be prepared in the pharmacy in enough time, and should be start sharp at 6 o'clock every day. The TBM, the new TBM. Yes, so there's a timeline for everything, all of this. So let us start now with, if you don't mind, with another scenario, but a little bit more complicated of intubated baby. So now this infant is not very bad. So that's a preterm, not congenital diaphragmatic hernia.
Okay, so we have a 24 plus weeker getting ready to deliver. So let's go over the transition checklist for infants born in less than 33 weeks. So we have a history. I'll give NICU and IMC a call. Lindsay, do you want to turn on the radiant warmer and put her on the bed? Alita, do you want to check the airway supplies and CPAP? Okay. Hello. Warm the NICU transport. Hello. So we're just going through the transition checklist. We have a 24 plus weeker. Okay. So Lindsay, you place a hat at the bedside and the warming mattress and the plastic wrap. Okay.
So I've told, I called the neonatologist, so he should be here soon. And you said NICU knows?
Yes.
Okay.
Okay. Have airway supplies and suction been checked?
Yes, we have a 2.5 and a 0.0 plate.
Okay. And do we have cardiorespiratory look downs?
Got it.
Yeah, there's leaking a little bit less.
So why don't, now that we're all here, why don't we introduce ourselves and then we can talk about the plan for this baby. I don't know the whole history, so I'm Nicole, I'm the nurse practitioner today.
I'm Monica, resus nurse 2.
And I'm Lindsay, resus nurse 1. Alita, respiratory therapy.
I'm Dr. Alvero, the neonatologist.
Okay, so we have a 39-year-old G4P0. She's had 3 spontaneous abortions. This is an IVF pregnancy at 24 and 3 out of 7 weeks gestation. Serology is negative. Mom was feeling unwell today, so she came in with uterine tenderness and cramping. So she was admitted for observation. Antenatal ultrasound is normal. She's received 1 dose of steroids. She ruptured her membranes 4 hours ago with a fever, and there's fetal tachycardia.
I talked to mom. She wants everything to be done, including epinephrine and chest compressions.
Okay, so get that ready.
So as far as the plan then, so we'll do the usual, once the baby's on the bed, we'll put them in the, him, right? It's a boy. We'll put him in the wrap, he's on the warming mattress. You'll put the CPAP on right away? Okay, perfect. And then see how he does. And you have stuff set up for an emergency UVC then?
Yeah, okay, yeah.
Yeah, this could be a sick baby, so
Yeah.
ready.
Okay, yeah, and we have a 2.5 endotracheal tube and a 0.0 bleed.
Okay, sounds good.
Okay, good with the plan. Timer started.
Okay, let's get him off
off the blanket
Yeah,
and in
there
the
is no
back.
breathing. There's some milking of the core.
Let's see, it's plus 7, around 30%. Okay, Lindsay, do you want to get some monitors on?
Yeah, he's not breathing. Yeah, brought it back.
It's pretty flat, yeah.
Are you on 7 now?
You can get a pre-deficit.
7, yeah, 30%.
Okay.
Heart rate's 90.
Heart rate's 90, yeah, he's still not really breathing.
Yeah, we're getting soft
Got the
now,
app.
64.
64.
Are we 1 minute yet?
45 seconds of it. Timer's right here and it's accurate. It's still not breathing, huh? Should we start some PPV?
Yeah, why don't we start
Okay, I'll hold
PPV,
this
yeah.
if you want to get the bag. Ready?
Heart rate's 90.
Yeah, I got it. Going up. Heart rate's. Heart rate's still 90.
Yeah, chest is not moving that well.
No, he did have some secretions. Let's suction out his mouth. I'll take this off. And a suction Lindsay. Did you get anything? A little bit?
Very small amount. Small amount of secretion.
Yeah. Is the mouth slightly open now? Good. What kind of pressure are you in?
Sacral 67%.
Okay.
There we go. Reposition his head.
7 minutes 45.
Minute 45.
That's acceptable for 2 minutes. The heart
Chest
rate
is
low.
moving with your bagging, I can see.
Yeah.
You have to go up on the apparatus with it. 40%.
Okay, we're at 40%.
Heart rate's still 90. Can you hear good air entry bilaterally?
Yeah.
He's not breathing, eh?
So we're at 2 minutes and 15 seconds. Heart rate still around 90. Thoughts are 70. So are we at 100% to leave it?
No, not yet. We're at 80% right now.
Yeah, 2.5 minutes. So what are you gonna do? Am I intubate? Can I give it fine?
Oh yeah, I guess we should probably intubate. Did mom get any medications at all, or?
What's that medication?
Steroids.
Okay, but
No.
nothing, no narcotics in the last few hours, or?
Yeah, I think we should intubate. How is not going now? The SATs are barely 70s now on 100% oxygen. He's not breathing.
Okay, and we're coming up to 3 minutes.
So I think we should intubate.
Okay, do you want to hold this and I'll get bandages?
Yeah.
Hello, so this is our NICU team, Dad. NICU, if you could just introduce yourself to Dad here.
Hi Dad, I'm Dr. Srinivasan, which is quite a mouthful. You can call me Ganesh or Dr. G, and we have the NICU team here. I'm Muhammad, Neonatal fellow.
Sebastian, I'm the RT.
Holly, one of the nurses.
I'm Jamie, and I'm also a nurse. Congratulations, and we're looking forward to looking after your little one.
So this little one, it's a little boy that was born 2 hours ago. He's 24, born at 24 weeks and 3 days. Birth weight is 550 grams. APGARs were 3, 6, and 8. Mom's a 39-year-old G4P0. SAs times 3, and this one was an IVF pregnancy. Mom was feeling unwell today, and she initially came in with some uterine tenderness and cramping. She was admitted for observation, and then her membranes did rupture, so that was about 4 hours prior to delivery. And she did have a bit of a temp as well, a little fever. She was just given 1 dose of steroids this morning, and there was some fetal tachycardia as well. Her serologies that we have are all negative, but the GBS is unknown. It was sent, but it is pending. The antenatal ultrasound was done at about 19 weeks, and it was a normal anatomy scan. So I'll let Monica give the, I should tell you, I guess, when the baby was first born, he wasn't very vigorous. He did require a little bit of PPV.
So the infant's appropriate, temp is stable at 36.7. We didn't give any meds for sedation. BP is stable, perfusion's good, and there's a UVC and UAC in situ.
And they're both in good position. So respiratory?
So we're intubated with a 2.5 ET tube, and it's 6.5 at the lips. We are on ACVG. Our VG is 2.2, which is 4 mLs per kilo. Our rate is 45, and the baby's breathing just as you above. Our peak is 7, and we're on 30% at VO2.
So Ganesh, this baby is quite stable right now. The X-rays show moderate HND before we gave it less. So I'm expecting the lung disease is minimal right now, so 25%, and it's very well saturated. I talked to mom and dad. They gave me consent for blood products and also for donor breast milk. And they know it's a very extreme premature baby. They want everything to be done. And mom hasn't seen the baby yet, so we gotta take some time to show baby to mom before we go.
Just from a respiratory perspective, we had a quick question. We had the jet ready because we were concerned when we looked at that X-ray with moderate RDS. You had a question about whether you need it or.
Yeah, I think right now he's quite stable, Ganesh, and he's only on 30%. I'm sure we can win a bit more, and the pressures are very low. So I don't think he's gonna need high frequency for now. He may actually be extubated by tomorrow, I hope.
And mom does plan to breastfeed, and she has started pumping.
So any other questions? Were you guys able to establish any peripheral IV prior to getting
There is a peripheral
IV
infusing as well.
And you did mention the caffeine was in, right?
Yeah. Yeah, we gave the load.
10 per kilo.
Okay.
Okay, so I guess we'll go to see mom and then we should be there in about half an hour.
Okay, I'll just highlight a few points before we get the question. So initially, we are anticipating really sick.
Okay, so we have a 24 plus weeker getting ready to deliver. So let's go over the transition checklist for infants born in less than 33 weeks. So we have a history.
Yeah, so we are anticipating really sick premature baby 24 weeker, and with rupture of membrane, maternal fever, so it's potential chorionitis. Although Robin was very keen to apply CPAP first, and was very hesitant to intubate. So he asked he called the nurse practitioner, and trying to justify a reason to intubate the baby. So he started ambubanging on 100% oxygen, and the infant's not breathing. And then at the end, there is no other way unless intubated. So intubated, given places a surfactant, that's our brand of surfactant. So that's a kind of maybe information.
As I said before in the presentation, the default is not intubation. The default should be always CPAP first. The baby needs to show you that he needs to have intubation. Okay? So prophylactic intubation is another question. There are some babies that definitely will need intubation sooner than 2 minutes. I'm not arguing with that. There are some babies that actually come out very, very sick, very flat. But it's never a reason not to at least try some nasal CPAP first.
Why you are not using the Neopap?
The Neopap has pros and cons. The problem with Neopap, the problem with Neopap, everybody familiar with the Neopap? Okay. So, as you know, the Neopap will give you a better control on the PEEP and the PIP, but it won't give you control of the TI, right? On the inspiratory time, because it depends how long you keep your finger. Okay, so if you're in a center in which the people that are going to look after these babies are not very comfortable with the anesthesia bag, I would say Neopap is a good choice. However, in our center, most of the RTs are extremely familiar with the anesthesia bag, and we think that you have much better control with the anesthesia bag, looking at the manometer, looking at the pressures all the time, than using a Neopap. With the Neopap, sometimes you get so comfortable with the Neopap that you forget to remove your finger, okay? And then you just need one long inspiratory time breath to. That's it. That's the problem.
But I'm not quite experienced with the anesthesia bag. could it deliver peak?
Oh, for sure.
Effectively, and you can monitor it.
Yes. But we have a dedicated RT that's the only thing she's doing or he's doing is that, just controlling how much pressure, P and PIP she's delivering and the rate.
So the one using the anti-CPAP, then
Yes. Yeah, RT is responsible for anything related to ventilation. I even set up the ventilation CPAP. That's his job. He just graduated from.
Actually, in entrance and even maybe we are not usually as neonatologists familiar with anti-CPAP. You usually use
Yeah, that's fine. You can use
that's why we are
the self-inflated bag.
We use this one. That's why the neopaf is a better option.
Definitely. If you're going to tell me you're going to use the self-inflating, I say, yeah, use the neopaf. There's no
question. I've always had the impression that we don't need to rush to intubate in the delivery room. We can use non-invasive ventilation.
Yes. Yeah. So in some units, they are using non-invasive ventilation in the delivery room. If you maybe, I'm not sure if you noticed that or not. That video was recorded 2015. That's 7 years ago. Yeah. Now we have the non-invasive ventilation synchronized, which is really advanced.
Usually when we teach anatomy, we expect on that point.
Yeah.
Do not rush to intubate. There's no hurry. You can.
Exactly. In this specific scenario, this infant might require surfactant, but still can be given in non-invasively by mist. Yeah. At that time, that was not really started yet. Now we have mist, we have non-invasive ventilation. That's 7 years ago.
And another point that once you are gonna use CPAP or non-invasive ventilation, we have to insert an engine tube to deflate the response.
Yeah, I don't know if we show that or not, but most of the time we put an engine tube right over.
Okay, sounds good. Any other question? Now we'll move to the next golden hour for congenital diaphragmatic hernia. Probably we have to maybe finish the next video before prayer time, and then I think we'll have the break.
Oh, great. Yes.
Yeah, the video is just a few minutes.
And I apologize for my acting skills.
No, you keep looking to the center.
So we have like about 5 minutes video, just the golden hour support for congenital diaphragmatic hernia case. So let us listen, and then we'll take a break. We'll come back for the rest of the day. Yeah, sure.
Okay, so I have our congenital diaphragmatic hernia pre-delivery checklist. Let's just go over it quickly. So I have obtained the history, and then I'll continue to do documentation.
Okay, it looks like I set up most of all the equipment behind this guy.
Yeah, and I've got the solutions ready to go on the pumps, some of the transducers, and I've across the medications.
Okay, sounds good.
Okay, Ron, so I have our congenital diaphragmatic hernia respiratory checklist. So I can just go through it. I'll assist with the intubation, so I'll be part of the airway management.
And I'll take care of setting up the conventional ventilator, turning on the graphics, getting the jet ready, and the nitric is here, and I'll key that in.
Okay, and I'm just going to double check the mouse mills are on and disconnected with 2 probes available. And I'll also get the inline suction available and just go through and check the equipment.
Great, ready to go.
All right, perfect.
So everybody has their individual checklist completed?
Yes.
Okay. We can do the history when the peds gets here. Get an estimate of the fetal weight.
Yeah.
Hi guys. Hi. Maybe we can start with identifying so we can make sure that everyone is all here who needs to be here. Okay, so would you like to start?
Sure. So I'm Monica, resus nurse 2. I have the history here, and I'll be in charge of documentation. So we have a 33-year-old G2P1 at 38 weeks gestation. Serology is negative, and she's GBS negative. Gestational diabetes, diet controlled. She received regular antenatal visits. Congenital diaphragmatic hernia was found at 20-week ultrasound. MRI was done at 32 weeks, which shows the liver and the abdomen. She received 2 doses of antenatal steroids about 3 days ago. Plan was for induction later this week, but labor started early this morning, and she ruptured her membranes about 1 hour ago.
So thank you for that. The only other thing I'd like to add is I did see this family prenatally, and the fetal assessment report also showed that the lung-head ratio was 1.2 to 1, and there were no signs of hydroxypatalis. So this baby, we expect, should be in relatively good condition.
Okay, and I'm Lindsay, I'm a resuscitator, so I'll be hands-on today.
I'm David from ICU. I'll be looking after the items and medications.
I'm Leah, I'm a respiratory therapist, and I'm going to assist with the intubation.
I'm Ron, I'm the second respiratory therapist, and I'll be in charge of the conventional ventilator, the jet, as well as the nitric oxide.
I'm Nicole, I'm a nurse practitioner, and I will be putting in the emergency UVC.
I'm Yasser, I'm a doctor, and I will do the intubation as soon as the baby comes in.
I'm Jared from pharmacy, and as per discussions before, I've got infusions of dopamine, morphine, and butyl ready to go, as well as the first doses of bedazzole and
Okay, and I'm Michael, I'm the neonatologist on the team, and I just wanted to run through, my role will be to be an event coordinator. We have everyone's roles have been identified, and so I will coordinate the efforts as we move to resuscitate this infant. One of the most important things will be doing things in an expeditious manner without this baby taking a lot of breaths. So to that end, we'd like to begin with Yasser. You said that you would do the endotracheal intubation, so we'll have you do that first, and ideally before this baby begins breathing. And then the next thing that will be important is getting that OG down and placed to suction so that we can decompress the bowel that's in the chest. The next step will be after we have the intubation done and the OG in place and the endotracheal tube secured, then Nicole, it'll be very important for you to come in and get that umbilical venous catheter in, okay? As far as the medications go, the first thing that I know I will do is ask you to provide some rocuronium that Jared has prepared for us. And then we'll give some midazolam and some fentanyl to keep this infant nicely sedated and free of any pain. As far as whether we'll use the other medications that were mentioned, dopamine, dobutamine, and even nitric oxide or the jet, we'll have to see how the infant is right after our resuscitative efforts. Okay? Is that keep? I did notify X-ray, and thank you for asking that question. And also, I took the liberty of notifying the surgeon on call. It's not urgent that they be here for the delivery because, as we know, the main issues that we will be facing are ventilation and pulmonary vascular resistance. Okay.
So then X-ray's going to be waiting outside.
They'll be right outside. Yeah. So, are there any questions? No, we're all clear. Okay. All right. Thank you. Okay, we have the baby here. Yeah, so okay, yeah, so you're going to take the head and do the intubation. And Nicole, you've got the UVC.
Yeah.
Okay, I'll be the event coordinator.
Skylight out. We have a CO2 detector. Color change. There's mist in the tube.
Okay, great job, Yasser.
Are you ready for the ventilator? Okay. We have 3.5 mL per kilo and a peak of 6, a rate of 50.
And our saturations are very good right now.
Alright, and I'm just going to stabilize the tube. Looks like we're about 9.5 at the lip.
As soon as they get that state, I'll come in for the
Monica, do you have the rocuronium, the fentanyl, and the midazolam ready? For after? Okay, so after she gets the UVC, and we'll give the medications, okay?
So So Monica, we have a 3.5, and it's 9.5 for this. Okay. And this is a 1 minus. Okay, perfect. Equal air entry.
The saturations remain really good. So great teamwork so far, guys.
So I'm just going to take it out. The secondary one. So I'm going to put it in just so I get blood return. I have blood return.
Okay, wonderful. So Monica, if you want to get the rocuronium.
Okay. So in 8 minutes, the team already discussed the initial debriefing, and that's a little bit extended team. So we have physician and nurse practitioner, or 2 physicians in-house, plus a neonatologist and a pharmacist with the preferred indication, and all of that
About 8
sorry?
8 to 9 persons.
Yes, and 2 nurses, 2 RPs, pharmacist, 2 physicians, in-house physician, plus a neonatologist, the leader of the team.
We didn't do a pre and post-doctor situation.
In this situation, yeah, initially the priority to start ventilation first, because if we do it from the beginning, for sure you will get it's just a transition. So we will sterilize everything, and then if you have the infant ventilated well with home air or low oxygen, as at 30%, so we don't have to do it. We're not expecting very significant pulmonary hypertension. So required, in spite of good ventilation, if I do 40-50% or higher, and we think that may require nitric oxide, which is already available, then we'll apply before we start that pre and post-start saturation. But the priority to get the arc line, the umbilical, both venous and the arterial line inserted, connected to the monitor, check the blood pressure, let the transitional circulation happen, and then connect adjust the ventilation, get the monitor the blood pressure assessed, and then maybe think about if this infant could be pulmonary hypertension, might need nitric oxide, although we ventilated the infant very well. And after insertion of the line, we'll get the X-ray to assess the tube, lung inflation, and then the line positions. So this is the sequence that should happen. Yeah, go ahead.
Yani we intubate the baby immediately. Yani whatever what will be.
And congenital diaphragmatic hernia, the default is intubation. Yeah, immediately. Yeah, now yesterday Ruben maybe discussed we may allow the infant to breathe, maybe but we used before to try as much as we can not to stimulate, to avoid any kind of breathing, and intubate immediately. And I think by physiology the infant might breathe few breaths, that's not a big issue.
Yani you trying to prevent the complication of diaphragmatic, to be fit more for pre-operative.
Exactly, yes. Because once you get a lot of air in the bowel, then that will be really difficult or challenging to inflate the lung, the contralateral, potentially healthy lung. So we need to avoid that. That's why we did 3 things: intubate as soon as possible, deflate the stomach and the intestine through the tube, this big tube, or reportable tube, and then start good sedation, because the infant started to breathe continuously a lot, some air might be swallowed and might distend the stomach and the intestine, and that's why we we consider muscle relaxant, like corconia or metconia, as frequent doses every 1 to 2 hours, if needed, if indicated, and then fentanyl midazolam for sedation, because the infant is intubated.
Is this recommendation also from surgery? Recommendation from surgery also to be more fitness for operation, or is this not related to operation surgery?
Yeah, it is related. Like, everything we do from the first minute after birth, it's a preparation for successful operation. Like to get the intestine decompressed, the lung inflated. The sooner that you prepare the infant for operation, even second day, the fit, that's a kind of success, because you will correct the pathology earlier and avoid ventilating like one lung or single lung, and the other lung did not get the chance to be inflated unless we get the surgery done. So we do that as soon as like we will try to communicate with the surgery. If the infant is fit for surgery second day, that can be done soon. Any comment, Robert?
Yeah, no, I think the time for surgery, as we explained yesterday, it depends a lot on the severity of hypertension. If a baby has an isolated diaphragmatic hernia with very low oxygen requirement, minimal hypertension, no inotrope, you can send the baby for surgery in the second or third year of life. There's no reason to delay that. Okay? But if you have a baby that is quite sick and requires a lot of support for hypertension or ventilation, then you want to wait a bit longer because you don't want to add the stress of the surgery on top of the severe hypertension and ventilation problems.
Okay, what about fetal surgery? This can be done?
I think we discussed that. Yeah. We don't have right now in our center. There is a program in Toronto that we can refer babies to for fetal surgery. Of course, you need to discuss that with the parents, and also you have to have the indication for fetal surgery. Usually, the fetal surgery is only reserved for babies with the most severe cases that have very poor outcome. So most babies, standard of care right now is still ultrasound surveillance.
Okay, it is better to deliver full term more than preterm.
Oh yeah,
so
for sure.
No need
There's no reason to deliver this baby preterm unless there's another reason why the mom needs to deliver the baby.
In this baby, the liver was in the thorax.
No, they said the abdomen. The abdomen.
And there was one.
If the liver is in the thorax, is there any problem with inserting the umbilical venous catheter, which has distorted anatomy?
Yes.
That's first question. Second question, is there any advantage of trying single lung ventilation to avoid rapid displacement of the mediastinum, which may have hemodynamic implication when the venous returns to the heart, and try one lung ventilation?
We don't. Most of these babies basically are one lung ventilation because the lung, the affected side is very hypoplastic, very small, and most of the time it's collapsed. At least until you do the surgery, because with the bowel in the chest and a small lung, it's almost impossible to expand that lung. So basically, you have to assume that you have to ventilate one lung.
But that's to say a little bit more depth of intubation to ventilate selectively.
No, we don't do that.
And for if the liver is in the thorax, do you apply an umbilical venous catheter?
Yes, we do, and it's a challenge sometimes because you're right. When you have the liver in the chest, sometimes the direction of the ductus venosus is quite abnormal, and it's harder to get the
right. It's harder to see by X-rays. That's why we have to confirm it by ultrasound. We use ultrasound to confirm, and if the tip is in the ductus venosus or in the inferior vena cava, because now they have the anatomy is certain. In X-ray, it's really a challenge to interpret it. That's why if the ultrasound shows it is in the ductus venosus or the inferior vena cava, even if it's like in the chest, that's still okay. Not in the abdomen. But if you can't get it in a right position, or if it is in the one of the hepatic veins, then we'll get it out and we'll insert the percutaneous PICC line. That's the alternative. So he's asking about using the single lung for surfactant.
without simulation هل في الريال لايف البروسيدورز الامبورتنت دي بتاخد فيديو فور destination of your recording with the meeting?
Yeah. So we have the setup. He's asking if there's a camera in the women's hospital. There is a camera in the station room. In each the new hospital, that's actually the simulation center. That's not the NICU. In our NICU, the station room, there is I think 4 beds, 4 right, and each one with the camera. And this camera, there's multifunction. It's connected to the maternal ward. So if the mom cannot come, she can like see what we are doing during the resuscitation, and we can communicate with mother. And while she's watching, because at each bed in the maternal room there is a screen, and this screen is connected. They can use for internet. Or it's connected to the TV. It's part of the room structure, and it's also connected to the central video of the hospital, so they can, parents or mom, she can watch whatever we are doing, and can maybe ask a question to the team or so.
Because documentation بين أي فيلم زي ما السيرجن بيسجل البروسيجر بتاع اوبريشن.
Yeah, it is recorded. It is. Yes, definitely. Like anything connected to the camera, it is already automatically recorded and can be reviewed. Reviewed for multiple reasons. For quality assessment if needed, to review if there is anything hidden, need to be reviewed, and also for education purposes.
I have a question. I wondered in both videos, you haven't shortened the endotracheal tube. It was a bit long. So is it a common practice that you do not?
No, we cut it. The practice to cut it.
Okay.
Yeah, because that will increase the dead space.
Yes.
We need to cut it, and that's actually the RT is responsible for that. They cut it and they connect the adapter. Exactly, it's just maybe 1 or 2 centimeters from the
away from the market.
Yes. So yeah, that's a very important question.
And you notice that in the 2 scenarios we're using a stylet.
Yes.
We try not to do that anymore.
Yeah.
Because we had a lot of issues, sometimes taking the stylet out, sometimes they get stuck, and it's too busy. So we try not to use stylets on
And now the laryngoscope is video recorded, not the old-fashioned one. So the video, you can you don't have to see you see it through the video.
We still use it.
So in the video it is recording as well.
Okay.
It's kind of endoscopy, so you can see the airways and the blood. It's very nice. Any other question?
For the
Okay. So rules that I bring